The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Welcome back to Sky Women's Health. I'm your host, Dr. Carolyn Moyers. If you've been listening for any time, you know my credentials. You know I'm a board-certified OBGYN, Menopause Society Certified Physician, Fellow of the International Society for the Study of Women's Sexual Health. And I founded Sky Women's Health because I believe that women in midlife deserve real answers, not dismissal. That's exactly what we're doing today. This is the Ask Me Anything episode. These are questions that came in from you, my patients, my followers, women in my community who are frustrated, confused, or just not getting the answers that they need from their doctors. Or getting misinformation from social media. And I hear it every single day in the office. And so I thought we would answer some of these big questions, from hormones to bleeding, to bladder leaks, to sex, to desire, to vulvar health, testosterone, and more. No topic is off limit. No question is too embarrassing. This is exactly the kind of just conversations that women deserve, and we will be having today. But before we get into it, I just finished in the OR and I'm going to go pick up kids later. So I wanted to quickly just tell you all just how incredibly grateful I am for the recognition that Sky Women's Health has been getting. This week has been phenomenal because if you're familiar with the Scout Guide in your community, we have been scouted and we had our photo shoot this week for that. We're very excited. And also, I was named as a Woman of Impact for 360 West magazine. And we had a phenomenal event last night. And I took the team so that we could celebrate together, because this does not happen in a silo. In order for me to carry out and be honest with all of the care that I intend to do for you at Sky Women's Health, it comes with the team who helps to make those visions come true. I tell them every day that they make dreams come true. So I'm just so incredibly grateful. And so whoever nominated me, thank you so much for the honor. It is just so refreshing. All right, let's get into it. Question number 1. I'm on menopausal hormone therapy and still having symptoms. What should I do? Okay, I always say if your menopause therapy is not working, it's either the dose, the route, or the formulation, and we just need to make adjustments. Perfect example, had a patient I just saw for follow-up this week. She came in for her annual. She's been pretty steady on her hormone therapy, but my natural cadence for patients is an annual exam with all of their blood work, and then if they're stable, they'll see me at 6-month intervals for hormone therapy specifically. And she reported that in the past 6 months, she had been having hot flashes and night sweats that weren't previously happening. So we did get an estrogen level to see how well she was absorbing. We adjusted her dose, and lo and behold, when I saw her for follow-up 8 weeks later, she's sleeping and her hot flashes and night sweats have gone away. So phenomenal. It's the magic happens in the edits. All right, number 2, my doctor prescribed CombiPatch, but I've heard progesterone isn't absorbed through the skin. Should I be worried? Now, this comes from a real life scenario. And you probably have heard me say many times that progesterone is not absorbed via the skin. And I know it can be very confusing because, yes, there is a CombiPatch. When we talk about progesterone, it's easy to use it interchangeably with progestins or progesterone, but we're actually talking about a umbrella of drugs called progestogens, a class of natural or synthetic steroid hormones that activate the progesterone receptors to regulate the menstrual cycle. Sometimes they're used in fertility to maintain pregnancies and promote reproductive health. This is in the levonorgestrel IUD, like a Mirena IUD or a Liletta, which can be used as part of your menopause hormone therapy, actually. But progesterone is your bioidentical option for endometrial protection, and it is too large of a molecule to be absorbed via the skin. So while creams may make you feel nice, it's not going to get a high enough absorption for you to have any protection of your uterine lining. When we are on adequate progesterone or progestins, our risk of endometrial cancer is actually at baseline. So there's no significant increase in risk of endometrial cancer when we have appropriate progesterone or progestins with our estrogen. Now, you might say, well, what's appropriate? That's for your doctor to know. Depends on the level of estrogen or the dose of estrogen that you're getting in terms of how much progesterone or progestin you need. Okay, so your progestins that fall under that umbrella of progestogens is your synthetic, and they're not bad. They work really great at stabilizing the endometrium and cycle control. So we like them for that reason. Norethindrone acetate and medroxyprogesterone are the typical ones that you will hear us talk about. There's also levonorgestrel that is in birth control. Norethindrone is another one. We have a progesterone only birth control. And you will find the synthetics in your CombiPatches. Or combo patches. So that's estradiol and norethindrone specifically in the CombiPatch. So the synthetics are actually absorbed through the skin. Can be absorbed through the skin. So they will help to protect the endometrial lining. So there is a difference between progesterone that is taken orally and has that lovely sedative effect that we take at bedtime, and progestins that are great at stabilizing the endometrium and protecting the uterine lining, controlling menstrual cycles. All right, next question. I've tried multiple hormone therapies and nothing is working. Is there anything left to try? Okay, this is a tough one, right? Because if you feel like you've tried everything, the chances are there are probably many options that you have not tried or were not aware of. And that just takes, us looking at a detailed history, looking at your health history, making sure that there's not any other ailments or comorbidities that could be underlying and creating your symptoms. Sometimes something as simple as a vitamin D deficiency or insulin resistance or a thyroid disorder, if we don't address those first, it can wreak havoc on your symptoms. But also just taking a detailed history and understanding, did you have dose adjustments? Did we try other delivery methods for your hormones? Did we check to see if we're absorbing them well? Because there's usually an option. Hormone therapy is so much more nuanced than anything I ever learned in residency. It was basically lowest effective dose for the shortest period of time. End of story. All right, I had breast cancer. Is hormone therapy completely off the table? The honest answer is it depends on your cancer type, the stage, the grade, your treatment. Did we have a double mastectomy? Did we have a lumpectomy? Did we have chemo, radiation, your symptoms, how much of those symptoms are affecting your quality of life? It's not a one size fits all, and absolutely never. So definitely something that has to have detailed conversation and looking at what your symptoms are. For instance, local vaginal estrogen therapy is a totally different conversation. If you're suffering from genitourinary symptoms, vaginal dryness, pain with sex, recurrent infections, a low-dose vaginal estrogen or vaginal DHEA is absolutely safe. There is minimal to no systemic absorption. The Menopause Society, in consensus with ACOG, actually even supports the use of vaginal DHEA in breast cancer survivors. We have a study published in JAMA Oncology in 2024 that looked at the use of vaginal estrogen therapy and in survival in breast cancer survivors. And there was no evidence of increased early breast cancer specific mortality in patients who use vaginal estrogen therapy compared with patients who did not use. So there was no increased risk of mortality or recurrence. So that is very exciting. So local therapy is generally always a yes, but systemic hormone therapy, it really depends again on your symptoms and your history and particular health goals. And then I always do appropriate counseling with consent forms signed because there's a lot of data that we just don't have yet, but I understand quality of life matters. You're more than just your breast. Okay, I was told I can't take hormone because I had a blood clot. Is that still true? Okay, it really depends on the circumstances of your blood clot. Number one, like, do we have a clotting disorder? Are we on anticoagulants? Did we have a blood clot after a motor vehicle accident or after surgery where we were immobilized for a period of time? Those things really matter because the answer may be that transdermal estrogen, so a patch, gel, spray, ring, that is delivered through the skin could actually be safe for you to use. Okay, why is that? It's because it bypasses the liver entirely. And when we bypass that first pass effect, then it doesn't affect the clotting factors in the same way. We're not increasing your fibrinogen and factor 7 and 10. So the details matter. If you've had a clot, just blanketly saying you can never have hormones is outdated. So the route of delivery really changes everything. What is the difference between bioidentical hormones and regular HRT? Is one safer? Oh, this question. You know, at this point, I just kind of roll my eyes when I hear this. It's kind of frustrating. Bioidentical is a marketing term, and it's a really great marketing term, but it does not mean that it means that it's reproducing what or replicating, mimicking what your body has always produced, right? So the ovaries produce estrogen, progesterone, testosterone. It is mimicking that. But when we talk about bioidentical, we often think that it's somehow safer. We're usually referring to compounding hormones that you get from the compounding pharmacy. And, with those, and I love my compounding pharmacists. I use them for several things that I cannot otherwise get. But with hormones, I worry about the safety, the consistency of dosing, and, between one compounding pharmacist and the other, the formulation may be a little different. So there definitely are concerns there on my part when I know that we have bioidentical options that are actually FDA approved and go through rigorous safety testing. And I know you're going to get consistent dosing. So one is not safer than the other unless you're considering, consistency of dosing and symptom relief. So it is a marketing term. It is unnecessary. Most people are shocked to find out that we have FDA approved bioidentical hormones that are covered by insurance. Okay, I have an IUD and no period. How do I know if I'm in menopause? It's a great question. Could also apply to having had endometrial ablation or having had a hysterectomy, but you kept your ovaries. How do you know if you're in menopause? Well, usually your symptoms are going to tell you, right? Whether it's that you're having hot flashes or night sweats or mood changes or disturbed sleep, or you just don't feel like yourself, or you're putting on abdominal weight, or vaginal dryness, urinary frequency, urgency. All of these things kind of play into those symptoms that usually will clue you in before you are, I guess the question is, are we perimenopausal or are we menopausal, right? And so what we can do is get an FSH level on 2 occasions, 6 weeks apart. And if they're both elevated, it's menopause. If one's elevated and one's normal, it's perimenopause. Because of the fluctuating hormones, the hypothalamus, the pituitary, they get mixed signals from the ovaries. And so sometimes we'll see that FSH go up and then down. But when we have two that are 6 weeks apart that are elevated, it's menopause. Okay, but the management does not change whether it's peri or menopause and you're not having a cycle. We treat the symptoms. Okay, next question. I'm in perimenopause. What are my options to stop monthly bleeding without a hysterectomy? Love this question because who wants to have a period at this phase of life? Okay, that can look like either a endometrial ablation is one option. So that would be like the step down from a hysterectomy would be an endometrial ablation. And you could do that with a hysteroscopy DNC where you actually go in with a camera, look around the endometrium, see what's going on, clean that out, and then do the endometrial ablation. Or it could be just done by itself, where you just go in and do the endometrial ablation, which burns or denudes the lining of the uterus. And the satisfaction rate is quite high. There are a couple of different kinds of endometrial ablation, and the success rate is pretty high as well. But your definition of success and mine may look very different. Whereas I may not want to have a period at all. You may be delighted that you're not having perimenopause heavy bleeding anymore, and you have a 3-day light cycle. So it's a little bit subjective in terms of like what success is, but it's generally very favorable, up to like 96% of women expressing satisfaction after the procedure. Then we have levonorgestrel IUD. So Mirena or Liletta are great options. We see a 80% reduction in bleeding the first 3 months, 90% reduction in bleeding in the first 6 months. And we have an indication for heavy menstrual bleeding for 5 years of use. So that IUD could serve you really well, and that especially if you're having the wonky perimenopausal bleeding. Okay, then we have norethindrone acetate is a fantastic one for controlling cycles. Even a small tablet of 5 milligrams can be really great at controlling that menstrual cycle. And this is one of those progestins that we can use. We also have Slind, which is a birth control, so that you would have a more regular, predictable bleeding pattern, because it's going to be that typical birth control pill pack where it's at 28 days and you've got 24 days of active pills and 4 days of inactive pills to give you that window to have a period. So for somebody who is comfortable having a menstrual cycle and they just want that to be better regulated and they tolerated birth control well in the past, you can absolutely use Slind. And then you could use estradiol on top of that. And that is, Slind is drospirenone. It's a 4 milligram drospirenone tablet. What else do we have? If we're having really heavy bleeding, you can use medroxyprogesterone acetate for a period of time to get that bleeding in control. And then my preference is to use one of the other methods. So those are the most common that are coming to mind for cycle control short of having a hysterectomy. All right, we've got some questions that we've kind of grouped into symptoms and diagnosis. So let's look at that. My doctor says that my hormone levels are normal, so I'm not in menopause, but I feel terrible. Who's right? The patient is right. So perimenopause, there is no lab that will define you as perimenopausal. Okay. So yes, we rule out underlying causes that could be masquerading, but just because your hormone levels are perfectly normal doesn't mean that you are not in perimenopause. Now, menopause is defined as being 12 months without a cycle, right? So if you're not having a cycle and we've done the FSH levels and they're not elevated, it's probably perimenopause. And you don't have to be 12 months without a cycle to start hormone therapy. So symptom relief is at your fingertips. It's just a matter of, a detailed conversation, because in perimenopause, it's a little more complicated to treat than menopause because we still have to worry about pregnancy and periods. So we have to kind of take into consideration those two factors when we're thinking through the different options and what might be right for you. All right, number 10, I'm menopausal and started bleeding. What does that mean? Okay, so I love this question. ACOG actually just published an updated guidance on evaluation of postmenopausal bleeding in April of this year. And the updated guidance recommended the combination of a transvaginal ultrasound and endometrial tissue sampling be part of the initial evaluation in most patients with postmenopausal bleeding. The transvaginal ultrasound with endometrial biopsy during initial evaluation for patients presenting with postmenopausal bleeding and endometrial thickness of 4 millimeters or less. The endometrial cancer is actually rising in the United States. The incidence is rising. And so that's why we've made this change in recommendations. 90% of patients who are diagnosed with endometrial cancer have postmenopausal bleeding, which is defined as a bleeding presumed to be from the uterus 12 or more months after that final menstrual period. And for some patients with postmenopausal bleeding, relying on an ultrasound alone may carry a greater risk of missing a cancer diagnosis. I will say this doesn't really shift how I practice. One thing I want to say is the update also addresses the disproportionate incidence of mortality rates in endometrial cancer among Black women, and the fact that this combination is super helpful for this population. We also want to consider a thinner endometrium when we're considering women of color because of that increased incidence. This doesn't change how I practice because I have always erred on the side of caution, whether it's an endometrial biopsy in the office, which is a blind biopsy, meaning, we're not visualizing anything. We're just taking a sampling of the lining of your uterus. But we can also do that through a hysteroscopy, dilation, and curettage, where we actually go in and sample the lining of the uterus. That is kind of the gold standard. So let's pretend that you're postmenopausal, you have bleeding, you get an ultrasound, your lining is right on that cusp, it's 4 millimeters, decide to get endometrial biopsy and it's benign. And you're fine until, 3 or 4 weeks later or a month later, you have postmenopausal bleeding again. The gold standard is then to do a hysteroscopy D&C, so we get a complete sampling of the lining of the uterus. Oh, here's a great question. I have no interest in sex and my vagina feels like sandpaper. My doctor told me to just use more lube. Is there really all I can do? Is that it? Okay, it's a great question. Every vagina loves estrogen. Okay, she needs estrogen. That can be delivered in a cream, in a tablet, in a suppository, in a ring, or vaginal DHEA. They are all reasonable options. Every vagina loves estrogen. My trifecta for a dry vagina is lube for any penetrative sex. And if we're not aroused, it's too early, right? We need to be aroused to a level of an 8, or it's not time to penetrate. A daily moisturizer. My favorites are Via by Solve Wellness and Medicine Mama, the Vulva Balm. And then vaginal estrogen, which is a prescription in the United States. Vaginal estrogen and DHEA are both FDA approved, highly effective treatments for menopausal symptoms like the vaginal dryness and painful intercourse and urinary urgency and frequency, and they reduce urinary tract infections. So use the vaginal estrogen until the day you die. We did have a recent study that compared vaginal estrogen to DHEA, and they both work great. Vaginal estrogen really helps to improve the vaginal mucosa. The vaginal DHEA is super effective for painful intercourse. And so sometimes we need to address with a different agent, but they both work on estrogen. The vaginal DHEA is unique in that it's a precursor to estrogen and testosterone, and the lower vagina has a lot of the estrogen testosterone receptors. Now, one caveat to that is, it takes about 8 to 12 weeks of consistent use for us to start to see that tissue improve. So if you're like, oh my God, this has been painful for so long, don't anticipate that you're going to receive results next week. But I've had plenty of patients who report an improvement in their urinary incontinence. They no longer have to get up to pee at night. They can finally have comfortable sex. However, if you're using your vaginal estrogen and you still find that you have pain at entry, so just at that introitus, that opening of the vagina, that is where we want to apply an estrogen testosterone cream that we get compounded because there's no other formulation of it. And we apply that to the introitus twice a day for 2 weeks, followed by daily for the next 12 weeks for symptom relief. And I've had many patients who graduate from using that and are able to have pain-free sex. Okay, next question. Do labia really change during menopause? And what should a proper vulvar exam look like? Okay, yes, the labia change. They may lose some volume, but the labia minora specifically can thin and start to fuse to the labia majora. Usually, the lower parts of the labia minora will fuse first, but we also see clitoral adhesions a lot. And most people do not examine the clitoris. Okay, so we lift back that clitoral hood. We should be able to see the entire glans clitoris and this landmark called the corona. And when we see that, we know that the clitoris is free. We don't have any adhesions. But sometimes you can only see, 10, 20, 30, 40, maybe 50% of that glans clitoris. Some patients with that will report pain with arousal or irritation with arousal or even muted orgasms. And so a proper vulva exam, I always start with a Q-tip and I touch across the mons, down the labia majora, then the labia minora. I look at the folds between the labia majora and minora. I spread open the labia minora, and then I'm touching with a Q-tip from the urethra all the way around the opening of the vagina like a clock. And then I'm lifting that clitoral hood and seeing if she's free. So we're looking at all the external skin to make sure that things are healthy. And that sometimes guides what type of vaginal estrogen I might recommend. Okay, two more questions. What are normal female testosterone levels? And how do we properly dose it? And what are the effects of having too high of testosterone levels? So, normal female testosterone levels are generally cited anywhere from 8 or 9 to up to 50 nanograms per deciliter, compared to 240 to 950 nanograms a deciliter in adult men. So, roughly a 10 to 20 times difference. And that's worth noting. Commercial lab references ranges don't account for menstrual cycle phase, and there's ongoing debate about establishing cycle specific physiologic ranges. What's clinically relevant? There are a lot of nuances to testosterone, but we do have a global consensus statement, and the International Society for the Study of Women's Sexual Health gives us guidelines on how to replace testosterone in women, and it is through a 1% testim gel, and we apply a pea-sized amount, usually 0.25 to zero point 0.5 milliliters a day, and we test your levels 4 to 6 weeks after starting, 12 weeks after starting. So you're having two levels after we're initiating testosterone to make sure that we're in a female physiologic range and we don't have a teenage boy's level of testosterone. And then we test every 6 months. So that is according to the guideline recommendation. So it is a transdermal gel applied daily unless we see that you're a super absorber and we need to adjust your dosing. Maybe we dose it every other day, or maybe we drop down your daily dose. The effects of having too high of testosterone in women. So let me tell you what I see in the office: an enlarged clitoris, but not better orgasms. Thinning of the scalp hair, which typically does not happen at a female physiologic dose. Chin hairs that are new and bothersome. Voice deepening. And here's the wild thing. I mean, I saw somebody this last week who was like, "Well, I haven't used testosterone pellets in years. Why would my clitoris be enlarged?" The clitoris doesn't go back down, nor does the voice changes that happen with super physiologic testosterone levels. And we see this sometimes in vocalists and singers that their voice changed and it doesn't return to normal. So, definitely something that we want to consider. I mean, think about PCOS patients. They don't want super elevated testosterone levels. They take medication to actively not have elevated testosterone levels. So, when we're replacing, we want to replace to a premenopausal physiologic range. Okay. How does Addyi work on the brain? This is our next question. How does Addyi work in the brain? And does it interact with antidepressants? Great question. And if you haven't watched The Little Pink Pill, you can watch it on Paramount, but it is an excellent documentary about Addyi and how it came to the market and the fights that they had to go through to try to get a female sexual drug approved. But how does it work? So, sexual desire is regulated by dopamine and norepinephrine, which enhances interest and desire, and serotonin, which inhibits it. So, that's this nice balance between excitatory and inhibitory. And flibanserin, which is the little pink pill, or Addyi, ADDYI, works by decreasing serotonin while simultaneously increasing dopamine and norepinephrine. And so it does help in some patients, about a 50% response rate, to improve their sexual desire, satisfaction, arousal, orgasms. Okay, in regards to the question about whether it's going to affect your antidepressants, this is a critically important question. Addyi is generally safe, but let's think about it from a pharmacokinetic, right? So SSRIs or antidepressants, a form of antidepressants are a strong CYP2C19 inhibitor, which is one of the liver enzymes that breaks down Addyi. And when that enzyme is blocked, flibanserin levels in your blood may rise, which could increase your risk of some of the side effects like a low blood pressure and fainting. And this is a labeled drug interaction that requires discussion when you're getting it prescribed by your physician. The second layer is conceptual, and this is one that probably doesn't get explained very much. But if your low desire is caused by your antidepressant, which is extremely common, Addyi is technically not indicated for that use. The FDA approval specifies that hypoactive sexual desire disorder may not be due to the effects of medication. So, an SSRI induced sexual dysfunction is a different clinical problem that needs to be addressed differently, whether it's adjusting your antidepressant, adding bupropion, or exploring other options. So, the short answer is Addyi and antidepressants could interact. And if your low desire started once you're on an antidepressant or after you started an antidepressant, that conversation needs to happen before anyone reaches for a new prescription for Addyi, adding another drug for a side effect of the first drug. So I know that can be truly frustrating. Okay, that's a wrap. To Ask Me Anything. We'll do this again sometime. We had a lot of questions I couldn't get to today. I hope what you have heard today is that so many of the things you've been told, you can't have hormones, just use more lube, this is just part of getting older, are not the full story. You deserve a physician who is current and is curious and who takes your quality of life seriously. If these are conversations you've been looking for, come find us at Sky Women's Health. Follow the podcast, share it with a friend. And if you're in Fort Worth, you can find us in the medical district. Check us out at skywomenshealth.com. Thanks for listening. This episode is sponsored by Sky Women's Health. If you love this episode, follow the show so you never miss one. Share it with the women in your life and help more people discover it. Let's make it binge-worthy.